Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center here in Towson, Maryland. We are continuing our medical tutorial series on the Whipple procedure. Today's topic is on pancreatic anastomotic techniques. As we've described in previous medical tutorials on the Whipple procedure, the pancreatic anastomosis, or the suturing of the jejunum or small intestine to the pancreas, is the Achilles heel of the operation. This is the pancreatic remnant. Pancreas. One of these days I'll learn how to spell it. So this is the pancreatic duct, and as a surgeon we like to determine whether the pancreas is firm or soft. So those are two different qualities that help in the decision making on which technique to use. And also the size of the pancreatic duct, if it's greater than 3 millimeters or less than 3 millimeters. Glands that are characterized as soft with ducts less than 3 millimeters are clearly glands that are at higher risk for leakage. So during the reconstruction phase of the Whipple procedure, what we do is we actually suture or reconnect the pancreas to the small intestine. The pancreas makes a fair amount of digestive juices. So the first technique that I like to describe is the duct to mucosa technique. This is my preferred method of doing the pancreatic anastomosis in the majority of cases. When the gland is soft and the duct is under 3 millimeters, I will change to alternative techniques. And when there are more than one way of doing something, there's clearly a reason for that, and that's because there is no perfect way of doing it. So what's my preference may not be another surgeon's preference, and so forth. I feel that performing this part of the operation in a technically proficient way and having a mental algorithm as how to proceed is extremely important in getting good results. So the majority of my cases are duct to mucosa. A small pinhole is made in the jejunum here. The mucosa is opened and sometimes sutured to the serosa, sometimes not. I use 2.5 loop magnification. I use 6.0 monofilament absorbable sutures such as PDS, and perform this anastomosis in a duct to mucosa fashion. I tend to use more sutures than other surgeons and approximate it very good. It's important to take deep bites in the pancreas with the needles. I do not place a pancreatic stent in the majority of cases, only if I'm not happy with one particular aspect of the anastomosis. May I place a stent? I don't feel the stents make that much difference. The majority of reasons why this anastomosis breaks down is probably more because of inflammation of the pancreas than anything else, or back pressure here. So I'm not particularly convinced that a stent makes any difference. So this is the duct to mucosa technique. After this part is completed, I do add additional seromuscular to capsule, more importantly to take tension off of the anastomosis than to actually reinforce it. So that was the duct to mucosa technique. Another technique is basically a 2-layer pancreatic jejunostomy, or an invagination technique. And in this technique, there are a few ways of doing this technique. I will only describe one. Instead of making a pinhole, the intestine is opened entirely this way. This is where the staple line is. Some surgeons take the staple line off and actually make it end to end. I tend to just open it this way. It's a two-layer technique where the first layer is the ceremuscular to capsule, and then the second layer is actually just deeper bites of the gland. And then when you get to the duct, you take a suture here, and so forth, and then you continue this anteriorly. So when you're done, it actually looks like it's rolled over or invaginated in a 360 fashion. Other ways of invaginating the pancreas exist. If you open the end of the jejunum, for example, you can actually roll it back on itself and actually begin suturing on the inside part here. So that'll be going to here, and then this part can roll over further back onto the capsule of the pancreas. So when you're done that technique, it almost looks like the pancreas has been stuffed into the bowel. And I will do this type of technique on occasion when the gland is very soft and doesn't hold sutures well. Sometimes you can even just place a tie snugly around the jejunum to make it more, to reinforce it more, instead of actually putting sutures here, because sometimes the soft pancreas won't even hold sutures. So it's easier to go ahead and just place a tie around it. It does require mobilization of the pancreas, however. And then finally, other techniques that have been described that I have no experience with and have never actually done, but there were some theoretical advantages to possibly suturing the pancreas to the stomach. And that would involve, and the reason might be that the stomach is a little thicker, it may hold sutures better, it may be better vascularized. These are all theoretical, of course. So this technique is where the pancreas is sutured to the posterior wall of the stomach in a situation like that, and then the anterior wall is closed over, and then the stomach is actually sutured to the small intestine. So the pancreatic juices actually enter into the stomach. I think this technique is more popular in Europe or in Japan than in the United States. But nonetheless, this is another technique that's been described